the outset, I would like to thank the organizers for inviting me. Uh, may I know how many are pathologists and how many gastroenterologists in the audience? Are most people pathologists? No. Okay, so I will stress. Okay. Okay, so today I'll be dealing with, now we go to malignancies, hepatocellular carcinomas, and I'll be dealing with the morphology and molecular classification. Um, my brief outline would be I'll see how we make a diagnosis of HCC and what are the subtypes of HCC which we morphologically classify, and if there is any information, clinical and prognostic information we can derive from this morphological classification, and the molecular classification and the immune classification, which helps us understand the hepatocellular carcinoma better. So how we make this diagnosis is we have the hepatocytes. This is a normal liver. We have what happens in malignancy, and how we recognize in the slide is that these hepatic cords, which are 1 to 2 cell thick, they become markedly thickened. So we have much thicker trabeculae, and these are lined with sinusoids, which are continuous and non-fenestrated, unlike the normal liver. And they show cytologic atypia, cytonuclear atypia, and as the grade increases, the cytonuclear atypia increases. And one of the ways in which we also recognize this is we see a loss of reticulin framework, which is normally present. So there is, in malignancies, there's loss of reticulin framework. So we commonly, for a well-differentiated hepatocellular carcinoma, sometimes that's the only stain we are relying on. There are some immunohistochemical markers that can help us identify hepatocytic lineage. So hepatocytic cells are positive for HepAR, arginase. They show albumin on in situ hybridization and glypican-3. So these are usually lineage markers. You can only identify that the cells are hepatocytes, so help in distinguishing hepatocytes versus other lineage tumors which can metastasize to liver. Out of this, glypican-3 is one which is only seen in malignant hepatocellular proliferation, so it is a marker of malignancy. And then there are others like glutamine synthetase and heat shock protein 17 beta-catenin, which are more seen in malignancies, and in combination can help us tilt a diagnosis towards malignancy versus, but these also have their own limitations of sensitivity and specificity. Coming to morphologic classification and the various subtypes, so 75% of the times that we normally see the hepatocellular carcinoma is a garden variety conventional hepatocellular carcinoma, and it shows a varied patterns which we call as non-specific, not otherwise specified. But about 25% of them show a typical or a very distinctive morphology which is different from the classical type. But having said that, hepatocellular carcinomas are morphologically very heterogeneous. Within a same tumor, you can find a lot of variety and a lot of patterns. So for defining some subtypes, we usually have a cutoff, like it should be more than 50% or more than 80%, showing a consistent morphology. So there are different subtypes, and now with the understanding of molecular, we have identified that these subtypes have they are morphologically and genomically, genetically very different from each other, and they have clinical outcomes also differ. So within the same category of HCC, we have a fibrolamellar hepatocellular carcinoma, which we can morphologically recognize by presence of these large, the cells are much larger and more oncocytic, and these have these fibrous bands which have a lamellar pattern. So it has a very distinctive appearance that we can recognize. And clinically, this also has a different clinical scenario in which it occurs. It usually occurs in young patients, and many of these patients are non-cirrhotic, and they have normal AFP levels. So clinical setting is usually different. And now it is known that they have a driver fusion. They have a distinctive defining fusion. So fibrolamellar hepatocellular carcinomas show this fusions, which is a DNA JB1 PRKA-CA fusion. So if you find this fusion in a liver tumor, that is a fibrolamellar carcinoma. So this is the driving fusion. And whenever we find a fusion, it is exciting from treatment point of view because these are easy to target. As of now, there are some experiments going on. We don't have a targeted therapy for this, but this is always an exciting news for a carcinoma. Prognosis-wise, this is the distinct clinico-pathologic entity, but has a prognosis in a non-cirrhotic liver is similar to a conventional HCC, but is better in cirrhotic patients. Then another type is the steatohepatic type, and this is which occurs in the clinical syndrome, metabolic syndrome, in a clinical setting of steatohepatitis and NASH or alcoholic liver disease. And this can be a difficult diagnosis on biopsy, distinguishing it from regular non-neoplastic steatohepatitis, because this is an HCC which shows features similar to, histologic features are also similar to steatohepatitis. So we have a on resected specimen, it is easier to make this diagnosis, and when the more than 50% of the tumor is showing features of steatohepatitis, then we call it a steatohepatic type. And it can show same features like steatosis, ballooning, and inflammation, and chicken wire pattern of pericellular fibrosis. So similar to steatohepatitis, this malignancy also shows, and the pathway in this is very different from the conventional hepatocellular carcinoma pathway. So the TERT, beta-catenin, and p53 mutations are the hallmark mutations of conventional HCC, whereas this shows a different pathway. It shows an immune pathway. It shows a more interleukin-6 JAK-STAT activation, so it has this inflammatory pathway. And this signaling is different than the conventional, so this is a very distinctive underlying molecular pathology. The prognosis is overall better, but it can be, many studies show it is similar also. There's another subtype where that more than 90 or more than 80% of the tumor shows clear cells, and that clear cells is because of glycogen. This can be a diagnostically challenging entity for us because it can mimic metastasis from kidney, from adrenocortical tumors, or clear cell neuroendocrine tumors. So pathologists need to be aware of this entity, and the clinical setting is, there's nothing remarkable about the clinical setting, and not much molecular data is available, but some of the groups have shown that IDH1 may be mutated, but it still requires verification. And prognostically, this has been found to be a better subtype. Now, this is the macrotubercular or massive hepatocellular carcinoma. This is the subtype which is associated with bad prognosis. This is the one which is associated with, now how do we define this is, here we find massively thickened trabeculae, or which are more than 10 cell thick across, and they more than 50% of the tumor is showing this pattern. Then we call it a macrotubercular HCC, and if we give out this in report, these are the ones which are associated with bad prognosis. These have high vascular invasion. They are usually associated with a high alpha fetoprotein levels. So, and these are usually seen in the setting of hepatitis B infections. And these are driven by p53 mutations, and they can also harbor FGF19 amplifications, for which various drug-targeted therapies are on the anvil. So this is a bad subtype. Another subtype is the Scaurus type. Like the name suggests, it has a lot of intratumoral fibrosis or sclerosis. And on imaging, it can mimic cholangiocarcinoma, and on pathology also it can be difficult distinguishing from cholangiocarcinoma because they have a lot of sclerosis, which is more common in cholangiocarcinomas. So this subtype has the TGF-beta type of signaling, which is usually a fibrogenic signaling, and it is associated with TSC1 and 2 mutations. So studies vary on its prognostic outcomes, but the larger Scaurus tumors are associated with worse prognosis. Another interesting entity is a chromophobe hepatocellular carcinoma. Now, you might be familiar with the chromophobe type of renal cell carcinoma. The similar appearance of tumor has also been reported in hepatocellular carcinomas. And these are also molecularly found to have a different pathogenesis of an alternative lengthening of telomeres. Clinical outcomes are not known to be very different. Another bad subtype is the neutrophil-rich hepatocellular carcinomas. This is something that on clinical investigations you will find are associated with high TLCs, and WBC counts are high, CRP is high, it has an inflamed phenotype. The liver biopsy shows the tumor has a lot of intratumoral neutrophils. And this is a tumor which produces GCSF and is associated with a worse prognosis. And then we have, on the other hand, lymphocyte-rich hepatocellular carcinoma. As the name suggests, has a lot of intratumoral lymphocytes. And the name from lymphoepithelioma, like carcinoma, was changed to lymphocyte-rich because these are not associated with EBV infections like other tumors, lymphoepithelial carcinomas elsewhere, right? So this is associated with a better prognosis and is a different thing. So basically, when we give you a certain subtype of hepatocellular carcinoma, it also gives a little bit of a prognostic information about its outcome, and also tells you that these morphologic subtypes are genetically very, very heterogeneous. So macrotubercular and the scarce ones are the ones which tend, and the neutrophil rich, they tend to behave much worse compared to the clear cell and the steatohepatitic type, and the fibrolamellar type in the cirrhotic. So morphologic subtypes tell us that there is a lot of morphologic intra as well as intratumoral heterogeneity in HCC, and these are associated with, this also tells you that molecularly also this tumor is divided, and also there's a good genotypic-phenotypic correlation, and there is a lot of prognostic information that can be derived if you have these subtypes. Very quickly to the molecular pathology. Because the topic is given to me is mainly dealing with molecular. So in HCC, what we have is a step-by-step acquisition of mutations along the stage from cirrhosis to dysplastic nodule to early HCC to progressed HCCs. And these are the list of mutations that you see in HCC. And the main mutations that drive hepatocellular tumorigenesis is the TERT promoter, TP53, and beta-catenin or CTNNB1 mutation. So these are the three key players which are basically active in most of the hepatocellular carcinomas. It's unfortunate, and you can see that these are not druggable. None of them is druggable. The other mutations which are in the range of 5 to 10, 20% are the ARED1, the SWI/SNF chromatin remodeling pathway. Then you also have these amplifications in FGF19 and VEGF, and then you also have the P16 pathway. And so what is interesting to see, and a lot of studies have been done which have shown that these TERT promoter mutations and the chromosomal instability that we see in HCC starts very early. So this is an early change. These are trunk gatekeeper alterations, and you can see that about 6% of the low-grade dysplastic nodules, about 19% of the high-grade dysplastic nodules, and about 51% of the small hepatocellular carcinomas, they already have these gatekeeper alterations in TERT and chromosomal instability. So this starts very early, and as the hepatocellular carcinoma evolves, there is a lot of genetic evolution. There is a lot of acquisition of further mutations, and if we a whole lot of studies and data from that we have learned that HCC is genetically a very, very heterogeneous disease. So within that's also one of the main challenge with HCC, because you have lots of clones which are developing in the same tumor. So it evolves with time and with treatment. So a multi-targeted approach to treatment is what is required for tackling this beast. So what we have reached now here is to the molecular classification. So broadly, if you see the hepatocellular carcinomas that we have, we know they are heterogeneous, but in the broadly, you can say half of them are the proliferating type, and half of them are the non-proliferators. And as you can probably guess, the proliferating ones are the worst ones, those which are associated with raised AFP, clinically bad prognosis, more associated with higher venous invasion, and these are the ones which are driven by P53. So I won't go too much into the details of this and make you sleep right in the morning, but what we have is that the proliferating type, you have further subclasses, and these are the ones which are, so the proliferation type is the worst type. p53 driven, whereas the non-proliferation is mainly driven by beta-catenin. And the p53 one, this proliferation type are the poorly differentiated on histology, whereas in the non-proliferators are well differentiated. So these are associated with a more aggressive behavior, more high rate of vascular invasion where compared to the non-proliferators, which are more of these well differentiated and lower AFP and low. So genomically and clinically, you have on a very broad level, you have two subtypes, the proliferators and the non-proliferators, and somewhere the genomic pathology and the immune classification also integrates into this, and we now understand that. For the lack of time, I'll just quickly, just briefly mention about the immune classes also, because immunotherapy is so important in HCC now. We have broadly an immune classification also, where you have the hot HCCs and the cold HCCs. These hot ones are the ones which have inflamed signatures, which have which have a very rich immune microenvironment, whereas the cold ones are the ones which are immune desertification happens, and there is not much immune milieu is not very active. So I'll skip all that and come to this that. So HCC is a tumor which is not only driven by the tumor mutations, but also has a dynamic interaction with the tumor immune microenvironment. So the immune milieu also has a lot of impact on how the tumor progresses. So there are hot and cold tumors immune-wise, and the ones which are hot, they are the ones which respond to checkpoint inhibitors. So unfortunately, there is no validated biomarker that can pick up which are the hot tumors and which are the cold tumors. But mechanistically, we understand this. And just one word about that, because this is a heterogeneous disease, because there are challenges that many times in HCC, you don't even have the biopsy, you don't have the tissue to do the molecular. So liquid biopsy is also an option where you can use it to overcome these challenges of heterogeneity, molecular and morphological. So there is an upcoming role of liquid biopsy in early detection of HCC on surveillance, in detection of minimal residual disease after curative therapies, and also for a molecular monitoring and therapeutic response. So what we have learned is basically that we have better understanding. There is a morphologic, genotypic, and phenotypic correlation that goes very well. And molecular and immune classes in HCC are both prognostic and predictive. And it is not just the tumor, but also the tumor microenvironment that is driving this hypothesis. There are lots of challenges because of the disease, but hopefully with all this information, we will move towards a solution. Thank you.
Thank you very much. We just have time for just one question.
That's a very nice talk. I just want to ask you whether you have done any molecular work. The reason is, I think 15 years ago, I was very interested in looking at this, and we had actually 20 cases of hepatitis B in those days, mostly autopsies, 15 cases and 5 dissection. Dr. Michael Dobbins was kind enough to do these studies in Johns Hopkins. We found out of 15 cases, maybe 2 we found the beta-catenin mutated, and 2 out of 10 had P53 positive. And genotype D was common in those 20 cases, wherever they can extract. So I just want to know what is the current thing, because it's many years since we have done that.
So while we know a lot about the molecular now, and we also know that there are broadly two P53, the worst one, and the beta-catenin, which is the good one, unfortunately, there are no druggable mutations as of now. So we do not get too many requests. We have, in our study, we got about 38% beta-catenin population, and those are the well-differentiated HCCs. But requisitions for this HCC is one. Even intrahepatic cholangiocarcinoma, we have a lot of molecular advancements in terms of therapy. But for HCC, unfortunately, we are still waiting for that breakthrough. So we do not have that much requests. But most of the times we get TERT mutations, which are seen in about 60%. And then we get P53 and beta-catenin. These are the 3 main players. So FGF19 is one of the targets, which is under certain trials. It is being explored whether FGF inhibitors can work in that. But otherwise, we're desperately hoping that HCC will throw
Yeah.
up some breakthrough.
I
in
think as
terms
a
of treatment.
pathologist, we use only immunohistochemistry like we have done for
So,
EPCAM and other
so
proliferative markers.
P53 and beta
we
catenin can
really
be
Yeah, yeah.
are
have this
IHCs. which-
discussion, I think, as
Thank you
just
very
one more last question from the
Just ask you a
chairperson.
question regarding the lineage markers for the diagnosis of HCC on true-cut biopsies. Which is the best one you would prefer, or you do the entire panel?
So it depends on the setting. So if the setting is well-differentiated hepatocellular lesion, where you're trying to distinguish between an well-differentiated HCC versus hepatic adenoma or dysplastic nodule versus, that is where where I have not found IHC is very useful. So you have all these sensitivities and specificities of all these markers, which can favor malignancy over benign. Those are still
question
the
is,
morphology is the gold
When
standard.
the tissue is limited, which one will you go for?
It depends on the setting. So this is one setting where we do IHCs. Second setting is when you're trying to make a diagnosis of HCC versus other mimics. Then you have a whole panel depending upon what your differentials are. And the third setting is when you are trying to do between a metastatic adenocarcinoma versus intrahepatic cholangio and an HCC. So these are the three different settings where IHCs have to be used based on what is the clinical setting, what is the slide showing. So there is no one marker solution for HCC. Yes. So I think we
So-
are short of time.
Yeah, on that note, thank you very much. We
Thank
really
you.
enjoyed
Thank you
it.
so much. Thank
And on behalf of my chairpersons, we end this session. Thank you very much.